football team. So really, what is it that makes a good football team? So I'll just kind of talk through this with you since you can't really respond to me with this slide. So generally you have to have skilled players. So and usually recruiting the guards, the halfbacks. Usually a good quarterback helps somebody to call the plays. Frequently you call the plays in a huddle when you're all together and you're talking about the plays. Usually good teams have a good playbook, so they've already outlined some of the plays that they know will be successful, and the plays may be unique to the kinds of defense certainly that's presented to the football teams. And usually everybody knows what the playbook is. They've studied the playbook. The guards know their position. The halfbacks know where to go. The ends know where to what kind of routes they need to run. And the one thing about good football teams is they generally have a goal, and that's usually if they want to score touchdowns, so they want to get across the goal line, but they also want to win the game on Saturday. But usually they practice a lot. So usually good teams practice all during the week for that goal of winning the game at the end of the week. Other good characteristics of good football teams are, well, my slides just went away, but we'll see if this is plugging. Oh, you can't. So other good characteristics is usually you have to have a field to play on. You have to have equipment. Usually a good coach. There's usually players along the sidelines that can come in and come and go whenever they need to. And so you can see that there are really a number of characteristics of teams, and usually it's not just one player, but the players all have to work together for this common goal. So, Kate, you want to advance to the next slide? So this is another team, and sometimes we don't think of orchestras and ensembles necessarily as teams. But you might think of this as another example. And when you think about, well, what makes a good orchestra or a good ensemble is usually people are skilled in what they do and the instrument that they play. They're also playing from a sheet of music and from a playbook. Usually a good leader or orchestra conductor is important. And when you think about an orchestra, the individual violin player or the cellist by themselves don't make the music. It's actually everybody working together and playing together creates that really the sound of that you're coming for. You also have, again, they practice a lot for that for the concert. Next slide. So with any good presentation, I think we need to have a good definition of what team-based care. And recently, the Institute of Medicine wrote a white paper. You can see that in the at the end of the presentation. But the definition of team-based healthcare is really the provision of health services to individuals, families, and/or their communities by at least two health providers. You need at least two people to interact with each other and to work collaboratively with their patients and their caregivers, and certainly to whatever is preferred to the patients and families, to accomplish shared goals within and across settings to achieve coordinated high-quality care. Next slide. And so I hope that you begin to see that we can use examples of other good teams maybe outside of healthcare to help us with understanding what may be some good characteristics of our own healthcare teams. What you see on your screen now is actually a healthcare team at Sacred Heart in Eugene, where this team meets once a day to review patients on the inpatient side, but this might be similar to a team that you might have in your own outpatient clinic or in your medical home that you're trying to develop. But in this group that's led by the care manager or care coordinator. There's a geriatrician, the nurse practitioner, the pharmacist. Frequently, the pharmacist is sitting at the computer, and as they go through the census of the patients on the inpatient side, they actually type in orders after their discussion so that everybody is really on the same page or playing from the same playbook, if you will, on the team. Next slide. So let's talk a little bit about what is a team. We've used this a lot. Many of us are members of many different teams. We may be a member of our own practice team. We may be part of a team in the hospital or on a quality improvement team. You may all have your own medical home team that you may be part of. So we use, you want to go ahead and advance that and one more time. So these are three words that we frequently use. When you think about multidisciplinary, we may come from different disciplines, but just putting people from different disciplines in the room doesn't mean that they're a team. You really need to interact with each other, and that's when they become interdisciplinary, and you need at least two people to interact in order to be interdisciplinary. But then there's a third concept that emerged over the last 5 or 10 years or so, called the interdependent team. And this is, or some people would call this the transdisciplinary team. But these are, this is a team which is very much dependent on each other. They communicate between each other, but it's more than that. They also know that their colleague will provide a task or a part of the process that is integral to the entire scope of care for a patient, and that they're interdependent on each other in order for that process to be accomplished. Next slide. So there are two words or two phrases that are used a lot, and I want to make sure that we try to distinguish them, because I think it's important to distinguish this. First of all is the word teamwork. And really, teamwork is a mode of functioning really between individuals. So between each other, we need to be able to communicate and interact with each other. And that this is really a term that's relationship-centric. It's about our relationships with others. Team-based care, on the other hand, is a specific approach to delivering health care that's really based on the foundation of the relationships that we have with each other in facilitating teamwork among the participants, but it's often we do this through processes and protocols within our practice. And the team-based care definition really is more process and task specific, although it's highly dependent on our ability to have relationships with others in our practice, but even outside of our practice. Next slide. So why do we do this? So I'm sure that many, if not most of you, have seen this home in this slide. But this really is to remind you that this is not a solo sport, that there is really probably no way that we can provide the 6 core attributes of a primary care, patient-centered medical home just by ourselves. And that as you build the rooms in your home around those 6 attributes, that just building the rooms isn't enough. They need to be interconnected. And that the interconnection really requires a group of individuals to be working together to accomplish building this home. Next slide. So why is it so hard? Why do we have a hard time developing teams in our practice? Well, there are a number of challenges. First of all, first challenge is, go ahead, is that many of us come from different disciplines. Many of us are trained either in schools of nursing or PA schools or schools of medicine, and within each of those schools, they have our own way of teaching and training that doesn't always and frequently doesn't interact with the other disciplines. And so we have folks that are coming into the room from different disciplines and different training. Next slide. The second is that we frequently aren't trained together. So how often do you see medical students and nursing students round together in the hospital? You don't see that very often. And that in the training together, we never really learn how to work together. The third is that there's generally a hierarchy, and that frequently the physician is the captain of the ship, if you will, and that this hierarchy sometimes gets in the way of our being able to empower others and to distribute the workload across a team. Next. We also we really practice in what's called asynchronous care, and I think the best way to describe this is to contrast that with synchronous care or synchronicity, which is more like the airline pilot getting into the plane and going down through the checklist that each time they fly a plane they check off the items and the procedures that they need to do. Well, that really doesn't happen very frequently in medicine. We actually practice in a field where everybody is different. We might use a different medication for one person than we might for another. They may react differently to it. We don't. It's not always very predictable, and so really our delivery method is asynchronous, and so it's very hard to predict what we're going to need the next day or even the next hour. The next challenge is really lack of continuity. Frequently, our patients may see me one day, but I may be gone the next day, or at night they may go to the emergency room, and that many times patients are being cared by other individuals that may not have all the information, and so it's very difficult to work together as a team when there isn't a lot of continuity. And then, quite frankly, our culture is really slow to change, and I think most folks would agree to that. It takes years for innovations and things that we know that work actually become implemented in our healthcare system. But next slide. So, but the last thing I wanted to share with you is another sort of potential barrier, and it has to come. It is about our ability to change within our practice, and a term called adaptive reserve. And for folks that have been examining and assessing the transformation of healthcare, this has become a very important topic in that it's really our ability to manage the amount of change that's happening in our practice. There's so much going on, and many of you are probably involved in more than just one quality improvement project. But really, it's the ability of the practice to be resilient, to really thrive and survive when they're under a lot of pressures. I mean, you're trying to make changes within your office. At the same time, you're trying to deliver great care every day, every hour. And for those practices that survive, that do the best, are the ones that really have the 6 components that are listed on this slide, and that it really very much is related to the relationships that we have within our practice. So I want to share with you a little bit about a model that I found to be helpful to think about teamwork and developing the relationships within our practice that creates highly effective teams. And it really is the interaction of us as individuals, but then there's also us as individuals within the context of the others that we work with, and that's really the team part. But teams exist not just within your practice, but they frequently exist within the larger organization, and that's really the interplay of all 3 of those that really leads to effective teams. I'm going to really focus more on the team perspective this afternoon. But before we go to there, I want to just make a few comments about individual. Go ahead, advance. There are a number of, all of us come to the table with our own personal skills and behaviors. Many folks in your practice may have had previously been part of EMT teams, or they may have been practiced in L&D or in the surgical suites, or they may have had experience in schools and other places from previous jobs of working in teams. And so everybody brings their own personal skills and behaviors to the team. The individual skill that that is very important is communication. We'll talk a little bit more about that in a little bit. But we all have our own way in which we like to communicate. You probably know of clinicians who love to be interrupted in the middle of a patient, knock on the door and say, you know, interrupt me when somebody calls, I want to talk with them. And then you have other clinicians who say, leave me a note at the end of the morning, I'll get to it. So we all have our own way in which we think about communication, but begin to recognize and acknowledge that we all have our own skills and styles of communication. The third really individual teamwork skill is the ability to lead teams. And certainly for those of you, I suspect, on this phone call, the reason that you're on this call is because you have some leadership role within the practice, or multiple leadership roles, and that the importance of leading is an individual skill that is extremely important to the team. I think that what is also important that's not on this slide is the ability for team leaders to also go back and forth between being team members. The ability to give up leadership and then also be a productive team member and allow others in the practice to become team leaders, and that understanding that going back and forth between those roles is really a skill in and of itself. The fourth skill, and I might just add that these are all, what I'm listing here are skills that have been observed and written about in the literature in terms of what we think are individual skills that lead to better teams. And this fourth one is really very interesting. You might think about this a bit, but the mutual performance monitoring. So this really is the individual team skill where individuals are really watching how your partners are practicing. So for example, if you were to be putting in a central line in the hospital or doing a procedure in your procedure room, the mutual performance monitoring is that I know that my colleague or my nurse or somebody there would stop me if they saw that I was doing something that shouldn't be done. That's a high-level teamwork skill, and the ability to give feedback to our partners about their own performance and monitoring that on a regular basis is really important. The other is backup behavior, the idea that that as an individual, I'm looking out after my partner. If I look on my schedule and I see, well, I had a couple of cancellations this afternoon, I see that my partner's trying to get to the 3 o'clock soccer game of their kid, then I might say I can really take a couple of extra patients, or you might pass on to the receptionist and others about your openings and your ability to take more patients, but the ability to begin to look and plan ahead and backing up your partners. And then finally, certainly a skill that we all need in the work that we do is being able to be adaptable. This is a profession that really requires adaptability. We never know what's going to walk through our door, and we need to be able to adapt to that. Okay, next slide. So we're going to spend a little time here in the next few minutes talking about, well, how do you actually develop teams? Surprisingly, there aren't a lot of formal methodologies out there around developing teams. What you're going to see here are 5 components of developing teams that I've called the team intervention bundle. I thought since everything else was a bundle in medicine that we could actually make a team intervention, a bundle also. But these are really sort of the 5, what I think are the 5 core elements from experience and work with teams over the last 15 years. I do want to bring your attention to another methodology that is in your materials or maybe on the website around team steps. And Team Steps really has been around for maybe about 10 years or so. Initially, it came out of the patient safety work in the hospital, and along with the Department of Defense work on teams, and they developed a Team Steps method. Maybe many of you out there have been involved with this. But one of the criticisms in the past has been that it's been way too hospital-centric. And so there is a new version out there that is specifically for primary care, and so I would encourage you to take a look at that. So let's talk about the 5 components from our perspective how to develop teams and what are the kinds of things you might be able to do in your practice to promote this. So the first component that has become very clear to me and others is that you have to have the leadership commitment. If the leadership, particularly at the organization level, isn't committed to this, then your ability to sustain the changes are less likely to succeed. The second part is the importance of practice and practice leadership. And I would say that you certainly don't need all of the clinicians in the practice to be gung-ho about developing teams, but you do need a champion, a clinician champion that will be willing to talk to their colleagues and to the rest of the staff and are really committed to this. If that's not present in a practice, then I frequently will tell practices that you need to get to that point because it really does require leadership commitment. The second key component to developing teams is really being able to define your team. Who is your team? You need to be able to identify the people, the individuals that are on your team, and they need to know also that they are actually part of a team. And the team, even within your practice, may be more than one. So as a nurse or an MA, you may be part of a small team of a clinician, an MA, and maybe a receptionist. Tom Bodenheimer and others in the VA have called these teamlets. But you may also be part of a larger team of maybe 4 or 5 clinicians that might be in the same practice, and you might identify yourself as part of a team there where you're sharing receptionists, sharing maybe lab, X-ray, MAs, and others. And then you may have a nursing care team. You may be within the practice there are a group of nurses that meet once or twice a month, but they're really focused on nursing care. So you may have a number of different teams, and we can talk about that if you have some questions later about that, but I think the important part is being able to define that. The other is to be able to begin to define the format of meeting together. We talk about football teams and orchestras practicing and getting together. It's hard to become a team if you're not in the same room together from time to time. And certainly an organized approach to developing teams requires people to have some predictability around when they're going to be together, and then what's sort of a standardized format. What are they going to talk about? On this slide, I suggest three topics, main topics. First of all, patients. I think that any kind of gathering or conference or team meeting should start with a patient, and that might be just a patient story. It might be and frequently you may do a case conference around a patient or two that are complicated, but that you really begin to ground this work around what's really important and the reason we're there, and that's around patient care, and it becomes much more relevant. Certainly, team meetings is a great opportunity to talk about performance, and then also to talk about operations. What kinds of things can you do to improve that? Next. So the third component is that it's always helpful to know to be able to measure how much teamness is there. And a number, about 10, now going on 12 years ago, we developed a measure called the Team Development Measure, and we're going to go into more detail about that. But that allows the team to tell you what they think about the attributes within the team. Are they present or are they not? And then be able to give feedback to them about where they might be able to improve their work as a team. The fourth component, and it is one that may surprise some folks, but this became very clear to us very early on, within the first couple of years of our work, is the need from our staff to understand their own communication between each other. That training our staff to communicate with each other, to acknowledge and to value each other's communication styles was a very important piece to moving their team forward. And then the last one is that, again, it comes back to the practice idea, is that is that really huddles and getting together on a regular basis, whether it's weekly or every other week, but some sort of a focused care conferences or huddles is a great way to practice. What you're doing is really practicing your communication skills, your interactions with each other, your teamwork together within the context of improving the care of the patient. And so I think we've discovered that that's a really valuable way in which teams are developed. So let's talk a little bit about the team development measure, and I'm going to walk through some of the attributes that this measure expresses. It's a 31-item tool. It's been accepted for publication and will come out probably in the next 4 to 6 months. But in the meantime, there's a website, the teamnessmeasure.org, where you can access the tool. The tool itself is also in the materials at the end of this presentation. But you can always also get the instructions for how to score this tool. But it's has very strong psychometric properties. When you look at the 31 items, they also divide out into 4 subdomains, or what I would call attributes of teams. Next slide. And these 4 attributes, if you look at the items, they cluster around 4 attributes. One is cohesion, and that each of these attributes seems to build on top of the other, and that over time your teams, sort of like on a yardstick, like on the left-hand side there, during the first 4 stages, they're really building those attributes, those 4 attributes over time, and then more advanced teams or teams that are more fully developed really become established with those attributes. And established really means that regardless of what happens within that practice or the team, whatever kinds of stresses that it might be a provider leading, it may be a change in who owns the practice or whatever, different stresses, that the culture of the team is still intact. And so the four attributes is the cohesion. It's really the social glue that keeps people together. It's the reason people get out of bed every morning and come to work. The communication seems to be the other very important piece that teams work on, where team members really are able to express what they feel and think, and address conflict, which we know happens frequently within a practice. That once you have the communication skills present and the team members really are able to communicate well, then they're actually able to have more deep discussions about what their role is and what their goals are, and to have really clearly defined roles and goals within the practice. And then finally, the 4th attribute is really the idea that the accomplishments of the team are above individuals. That this is a we, not a me, type of culture that you're practicing in. Next slide. So let's look at each of the attributes that are for a minute here, and let me talk about a few interventions that I've observed and actually experienced that I think really help with developing these attributes. The first one is this social glue, the idea that people come up and have a job, or they come to practice for a reason. And certainly one of the interventions that I think is helpful is hiring people that really want to work in this type of environment. So it's sort of the hiring for fit. And this might even include, as you're hiring somebody, that you interview folks in teams. There may be 3 or 4 individuals within your practice that interview folks, but you really want somebody who thinks about practicing as a team as opposed to a solo individual. Understanding what the team member's passion is. You know, folks come to work with a lot of interest. We had a patient access specialist, a receptionist, who was very passionate about having a warm, welcoming experience for patients as they came into the waiting room. And so she was really focused on making that a place that was very welcoming to patients. We really focused on using the we language. So it no longer became my patient. This wasn't Dr. Stock's patient. This wasn't my patient. This became our patient. This became our team, or our practice, and that we actually gave each other permission to correct each other when we started using me and I and mine, and we started using different language. And that can be a real powerful way to get people to start thinking a little bit different. And then finally, one of the things we don't do, I think, all that great in medicine, we don't celebrate enough. You know, ice cream cakes really work. And having, you know, celebrating when we do well, when we perform well, and something good happens. Next. So the second attribute is communication. And again, this is really beginning to master the ability to say what you feel and think, are truthful, addressing conflict maturely. We tend to be a conflict-averse profession, and the idea here is to really begin to think about conflict as being a place where you might be able to resolve some differences and actually make things better toward the end, and that there are ways in which you can actually embrace conflict in a very positive way. Working through communication styles, practicing through getting people together in the same room, doing huddles, actually having conversations, and particularly conversations that are patient within the context of patient care. And then leaders are really important here because they can model many of the good communication skills. The third attribute is really how do you build team roles and goals. Some ways to do this is to actually have your staff write out what they think they should be doing. And you might take that, 2 or 3 minutes or 5 minutes within a practice team meeting, have them share that with everyone else and to check in and validate or not validate whether this is what they were supposed to be doing in this practice. But it begins to help folks understand what their role is in the practice. I think exposing the team to different roles, so inviting in the home health nurse or the hospice nurse who might be working with your patients, but the only time, but you never see them, you only see them through the letters and the reports that they send to you, or maybe over the phone. But having them come and talk a little bit about why they do the work they do, and some of the ways in which they might actually interact with you in a better way. You might do that with a pharmacist that might be across the street, or with a physical therapist. As a geriatrician, that was extremely important, is to have the physical therapy in the room and share what they can do to help with falls in the elderly, or how we might want to work together with therapy protocols. Also, flow charting your clinical processes. I suspect that many of you out there have been doing a lot of this, doing process mapping. This is really a great way to begin to solidify and clarify who's doing what and who's accountable for some of the processes in place. Next. And then finally, the team primacy, the idea of accomplishments of the team are above individuals. I think everybody needs to understand what the mission is in the practice. Why are they there? What are we trying to accomplish? Soliciting input from many people during the meetings, that it isn't dominated by the clinician or by the manager, but that the role of the clinician and manager as leaders is to really begin to facilitate that discussion of other individuals in the practice. Having the team help you develop the quality improvement agenda, asking them what they think they need the most help with. That allows them to have some interest and skin in the game, if you will, and for you to be transparent about what the outcomes are. Next. I put a slide in here around leadership because although the tool doesn't measure leadership directly, I think that leadership is another core attribute within teams, and this is really a slide to remind you of what those leadership roles are. What's not on there is I usually have another slide that says the first bullet is to show up. So it's really important that leaders are present, that they show up on time. It's a great example to the rest of the team of the importance of that role. Having unambiguous support, the role of the leader is really to set the direction and then allow the team to, are empowered to develop the means to go down that road to accomplish the goal. We found that supporting managers is really a critical piece here. Frequently, managers within practices are the ones who really see the day-to-day interaction with staff, a lot of personnel issues, and this is really a place where you can make or break some of the team concepts. And supporting a manager around the team concepts is important. Creating a learning environment, I think we all need to be considered in a learning environment. It creates a much better culture. Again, inspiring, rewarding, and celebrating is really the role of the leader within the practice. Next. So I'm just going to take a few minutes here and give you some real data about what we've seen with the team development measure with some real teams. So this is a team, and what you'll see along the x-axis is really the yardstick of the measure. It's 0 to 100. Each of the blue bars is an individual. I think in the middle there are 2 individuals. But you can see that on a 0 to 100 scale, on the left-hand side there's somebody who does not think there's much of a team present in the practice. And way on the right side, there's somebody who thinks that that this is really a great team and that this is a wonderful place, likely a wonderful place to work. And so my point here is that when you first use this tool, what you're going to see is really a wide variation of opinions about whether there's teamness within the practice or not. And that's really very typical of a practice. We all have our own perceptions of what's going on. Next slide. So, 4 months later, when you give use the tool in the same group, what you see here is that the average of the whole practice of the team really didn't change very much. But what really changed was the variability. So this is really about, certainly early on with teams, this is really about getting everybody on the same page about what we're talking about and what are the attributes of being a team. And what we feel is that once folks are on the same page, they can actually begin to move up the scale of becoming more effective team together. And so really the first goal, I believe, is really reducing variability about what we're trying to do within the practice. So this is a graph of 42 clinics within a healthcare system, and it's really an illustration that the solid line across the top is what we think are the score of teams that are really where it's really become part of the culture. And you can see there are very few. I think maybe there's 4 or maybe 5 teams out of 42, and there's a lot of variability. Even though many of these teams were actually located pretty close to each other. Next slide. So actually, I won't have you go back. So one of the things we were interested in knowing was if of the 31 items in the team development measure, which item was the most predictable of whether there was a team, whether teamness was present in the clinic. And so the next slide. So this was the one item that was the best predictor. The best predictor was, regardless of the topic, communication between the people in my work unit and department is direct, truthful, respectful, and positive. So of all the 31 items, if we focused on that one, we'd probably make some progress, at least in terms of developing. And again, this supports the idea that communication between each other is really critical to moving this forward. Next slide. When we looked at organizational health between the clinics that were part of a team intervention, and this is organizational health, I guess you might say staff satisfaction, we did see a significant difference of those practices that had teams present as compared to those that were less team-like. And when you ask patients, so this was pre-CAPS, pre-press gating, we did this work and looked at asked patients questions about specifically around the teamwork of the clinic staff who took care of you during your visit was the single strongest predictor of overall satisfaction with the care and service within that practice. So there are a number of issues. I'm going to wrap it up here so we have a little bit of chance to for you all to ask some questions this afternoon. But I did want to outline a few of what are really important team issues. I hope that maybe we could get to some of this in about a month from now when we do another webinar. But I'm sure none of these will be particularly surprising to you. But certainly the idea of communication training, we know it's important, but how do you do it? What's the best technique to do it? I can tell you that there is no standard way of doing it. There are a number of seminars, a number of interventions that have been effective. But it also requires taking time out of the clinic and at least an afternoon to begin to do some of that work with your staff and your team. Conflict management, as I mentioned, we tend to be in a profession that's conflict averse. And so we try to stay away from that when in fact we really need to address some of that from time to time, and it can be addressed in an adult professional way. And certainly communication helps with that. What do you do when somebody doesn't want to be part of the team? What if one of your doctors or nurse practitioners or key individuals don't want to be a team player? What happens with that within the practice? Where do patients and families fit into the team here? There is a document at the end on a white paper that was written for the Institute of Medicine on team-based care that I participated on. I'm also currently participating in an Institute of Medicine task force that's writing a paper on where do patients and families fit. What's the role within the practice? And it's complex. In a word. And then leadership. You have formal leadership, but we all know there's informal leadership. How do you identify that? How do you use that to really help move your teams forward? What happens when members come and go? Do you have a process in place for addressing that? And then finally, an issue that comes up from time to time is really boundaries. Where is our boundary in terms of, as a team, will we in our interactions with patients, do we take care of all their needs, or are there boundaries around that? And do staff have boundaries about what they can and cannot do? So the next slide here are just some handouts and some links. I think I've mentioned most of them, except for maybe the second bullet there. So that's just the first bullet. So you'll find the Team Development Measure Questionnaire. For scoring the measure, at this point, you'll need to go to the website, the www.teammeasure.org. But there's also an action plan worksheet that helps you sort of identify the 2 or 3 items that your team, your practice may want to work on. What I would advise you, if you do use this instrument, that when you provide feedback to the practice, that you allow them some time, number one, to review the information beforehand, that they come and you ask them about, just in general, what they thought about the information and the questions. But then you then focus on the 2 or 3 items out of the 31 where some folks was present and other folks disagreed. Those are the items where there is a mismatch between different folks around the table, is where you will find the most success and the most benefit. That's much better to focus on that, on those items, as opposed to those items that everybody agrees to isn't present. So again, kind of reducing the variability, getting everybody on the same page before you can move up the scale. There's a handout in there also on the tips for successful teamwork. This came from a group of geriatricians at Rush Medical Center who I worked with about 10 years ago. And it's really there are 8 core principles. One of the interventions that we used using this particular handout was we took one of the principles and had a staff member facilitate a discussion for 5 or 10 minutes at each different team meeting, so that you didn't go through it all at once, but you might use a little bit of time during your team meeting for one of your team members to facilitate a discussion around that key component and come up with ideas that you might use to facilitate that within your practice. We talked about team steps and then the core principles, the Institute of Medicine manuscript. So this is my last slide and some final thoughts. And in general, I hope you understand by now that teams just don't happen. Just putting a group of people in the room, having them sit around the table does not make a team. That training really is necessary and important to pay attention to that. That leadership is critical and commitment to doing this. This is not like sticking your toe in the water, and if it gets too complicated, gets too high, you pull yourself out. It becomes actually quite detrimental to the team as a whole. You really need to really commit yourself to doing this kind of work. And it requires ongoing maintenance and practice. My experience is that at least for teams where I've seen that have started from scratch, it takes about 2 years for them to get there. Practices that have already been in practice and maybe staffed there for a long time, it's a little bit hard to know how long it takes to get rid of some of the old habits and to think about some of the new ways of interacting with each other. But the point here is that it really takes time. It's 24/7, 365. This is not a workshop, and just doing a workshop is going to make you a team. Measuring, giving feedback, and it will pay off. We've seen this over and over again. So I'm going to stop there. Let's find out if there are any questions. Okay.
Hi, this is Kate. You may see some slide switcheroo on your screen. The technology did not work perfectly as it is wont to do in life. So I'm going to just go ahead and take questions anyway. So you may see something, probably my desktop, on your screen. My apologies, but we would like to go ahead and get to your questions. So as a reminder, you can type in your questions to the questions pane, and I do see a few there. And we are also happy to take questions from folks who raise their hand using the hand-raising feature. You will have had to enter your audio pin so that I can unmute your line, but if you'd like to go ahead and ask your question yourself, you can use the hand-raising feature. I will let you know that I'm about to unmute you, and you can go ahead and ask your question. In the meantime, while people are deciding if they're brave enough to ask their questions themselves, there are some questions that came in through the chat that I'll go ahead with. So one question is, what is the expectation of a team in the event a client requires specialty services outside of the PCPCH, including mental health services?
Yeah, so there are actually a couple of questions there. First of all, I think that what we talked about mostly this afternoon is within our own practice and how to develop a team there. But I may have failed to recognize or acknowledge that, we work with other practices, you work with specialists, you work with the hospital, you work with a number of other, maybe the ED or the urgent care teams, and recognize that they have their own team and culture as well, but that it's important, I think, at least from a practice's perspective, is to reach out to them. Some ideas that you might consider if there is if in your practice you have may send a lot of folks to a pain specialist, for example. You might invite the pain clinician or their staff to one of your meetings, and you have a discussion about how you might have a better interaction between each other, how you might get patients, what they think about the management and maybe the clinical management of pain. But you might also talk with them about how can we more smoothly get our patients in an effective way to your practice, and what kinds of information can you always count on us to provide for you. So that's just an example of where you might begin to reach out to other specialists or entities and begin to think about how you might work more like a meta team within the community. Behavioral health or mental health would be really another example of that, and certainly I've been an advocate of integrating mental health within the practice. So you might have someone, either an LCSW, or you may have a psychologist or even a psychiatrist that might come to your practice, or you might invite them to a team to talk about how you might begin to make more smoothly the transitions and referrals of patients who might previously you get them in to see somebody in maybe a month or 6 weeks, but if there was an understanding and a process in place, maybe you'd be able to get somebody at least available by phone in a much shorter period of time. So I think there's ways in which you can begin to develop processes that are more team-based. I hope that sort of answers their question.
Yeah, great. So there was one other question that came in through the questions pane, and that was, are there any tools out there for clinics to use and score the team development measure? And I know we answered that, but maybe you could just talk a little bit more about what's available online for people to use that.
So for the team development measure, the scoring algorithms are located at the website, the www.teammeasure.org. If you Google Team Measure, it has, at least in the last couple of years, come up #1. So, and then if you go to that site, you can actually download the PDF of the tool, but it also has a tab for explaining how to score the tool. There are a few of the items that are reverse oriented, so a disagree would be positive and an agree would be negative. So there are a few of those, but that you can access that information at the website.
Okay. Looks like we may have time for one more question if there's anyone who wants to type into the question pane or raise their hand. Give me just a moment to review what has come in. It looks like we did get a couple additional questions about accessing the tools and the slides. So again, a recording of today's webinar and the slides will be posted to the website along with a couple of handouts and some materials related to the team development measure. And then there was a question that came in about, can you talk about the importance of co-location of teams?
Yeah, so that's a really good question, and I think it's I'm not sure it's co-location of teams. I guess it could be in two different ways. I think that co-location of staff and what has in some of the redesign work that I've been part of and what I'm seeing happening in other practices in the state is actually beginning to put care managers, and they may be nurses, some may be social workers, but receptionists and even providers in the same room together. I'm actually an advocate of that because it really begins to allow take down the barriers of communication again between receptionists and clinicians, between nurse care managers. There's a lot more sort of getting the right care to the right person at the right time. You can really take care of a lot of things in the moment that really is much more efficient and effective for patients, and they get I think they get better care that way. So I like the idea of physically co-locating and having that in your practice. The idea of co-locating other teams, I'm not quite sure what that means, but certainly your practice may have a number of providers that may be in what we call maybe pods has been another word that's been used. But having a structured time when they actually interact, if they're not in a same physical space, but that there be some understanding that at some point, maybe once a week or every other week, that there would be some interaction physically, face-to-face with that would be good. Some practices have experimented with bringing specialists in their practice and having them present during certain times of the week, and beginning to, at least on a intermittent basis, co-locating in the same space.
Great, and then I think we have time for one last question that came in. The question is, I work in a practice that has 9 providers and 14 residents. What is your ideal team size to be effective?
Yeah, so that's a really great question. When you think about it, it's really going to be individual to your practice. But when you think about it, I would ask the question. Number one, I'd ask the question: if you were to ask your patients, what would they say their team? Who would be on their team? And so that might be one good place to start. And usually, what that means is that the lowest common denominator would be the clinician, and their MA or nurse and the receptionists are kind of that teamlet. So you may actually have a couple of different levels here, and so that might be one of your your team. In terms of the 9 clinicians and 14 residents, that gets pretty big, but it's not unreasonable. I've seen teams, and certainly the team development measure has been validated with teams as small as 3 and as many as 31. So I think certainly the optimal size, I think, is probably around 15 to 20 or somewhere in there. You get up into closer to 30, it may be hard for everybody to be acknowledged and to get feedback, and for people to feel like they're really engaged in the team practice. So certainly the smaller teams, I think you have some opportunity, and then sometimes the teams can get a little bit too large.
Okay, so this is Kate again. We're right at 1 o'clock, so I know everyone has work to certainly get off and do, but I just wanted to give you a couple of reminders. You'll get a follow-up email today with a link to the recorded webinar, the slides, the materials, and also a link to a follow-up webinar to this one that'll dive deeper into some of the challenges and how practices have how practices have developed some successful strategies to address those challenges. So that may be of interest to you. This was sort of a part one, and that can be a part two to address some of the things we know people get caught up on. Finally, as you sign off today, the survey will come up on your screen. You can give us some feedback on the webinar today and let us know what you thought and what you would like to see in this part two webinar in June. And then also provide any additional questions that I can forward to Dr. Stock and get back to you about if we didn't have time for them today. So I really appreciate Dr. Stock being here today to share this great information with us. And please leave any other comments you have in the survey. Thanks so much.